Good morning, everyone. Our respected sir, our senior colleagues, and my juniors. So today we are going to talk about a review article, which uh, explains briefly about the landmark studies regarding the mediastinal lymph node staging for non-small cell lung cancer. So the topic is the landmark series advances in preoperative mediastinal lymph node staging for non-small cell lung cancer. And so before going to the article itself, let's briefly talk about lung cancer. It is the most common non-melanomatous malignancy in the world and is the most common cause of cancer-related mortality, with a relatively very low proportion of the patient that actually present in the surgically treatable stage. There is a massive gap in the surgical patients and the medically treated patient in case of lung cancer. Globocan is a very important study of an organization that shows cancer-related research in different part of the world. So, in the last Globocan 2022 report, it shows about 2 million people were affected by lung cancer, and has shown the progression as the projection of lung cancer can increase massively globally, potentially reaching up to 4.62 million new cases and about 3.55 million deaths by 2050. So this picture here shows I have to bag my eyes. Sorry. So this picture here shows the massive amount of patients actually affected by lung cancer in males. And when we talk about both male and female sexes, still lung cancer comes as the most common cause of cancer and most common cause of cancer-related death in patients. Now, so where do we stand? Talking about Nepal, we had a total of 2,431 cases reported in 2022. These might be underreported as well, but still, the scenario is similar as global. We have more lung cancer patients than any other cancers. So, why do we have to study about the nodal staging? And if we talk about the effect of lymph node metastasis, it is quite significant. As here we can see, this image has been taken from the IASLC nodal staging manual, and it shows the significant differences in the survival of the patients with or without lymph node metastasis. As we can see, the N0 patients have a very higher survival advantage as compared to the those patients with nodal metastasis. So briefly talking about how the nodal station are defined as per the 9th edition of the ISLC nodal chart. Here we can see the image of what are the stations. The cervical and supraclavicular lymph node station 1 and different superior mediastinal nodes, which include the 2R, 2L, 3A, 3P, 4R, 4L, and aortic nodes, the 6 and 5, and the 7 subcarinal inferior mediastinal nodes as 7, 8, 9. So N1 nodes are those nodes which are from level 10, station 10 to 14. So which are primarily inside the lungs. So now moving toward the article of discussion today. It was published in March 1st, 2025 in Thoracic Oncology and Esophageal Cancer Journal. So this is an open access article and was was written by Alison S. Paskin and the colleagues. So talking about this article, currently clinical guidelines recommend preoperative invasive mediastinal staging for most patients with potentially resectable lung cancer. So invasive includes either surgical or non-surgical. In surgical, it is cervical mediastinoscopy or video-assisted thoracic surgery, while non-surgical, still minimally invasive, are EUS or EBUS guided FNAC. So this review examines the 5 key trials that has impacted significantly in the mediastinal nodal staging. So it also explores the expanding role of endobronchial and endoscopic techniques in mediastinal staging for non-small cell lung cancer. So it begins with the obtaining of contrast-enhanced CT chest of the patient. Sometimes we can also use PET scan or combined PET CT. So these are the main studies that have been included and reviewed in this article. So the first one is by Hirth et al. In 2006, which evaluated the EBUS TBNA and its efficacy. In 2008, Wallace and colleagues studied the TBNA versus EBUS versus EUS versus combination of EBUS and EUS. 2010, Enema and colleagues studied surgical staging, that is mediastinoscopy versus EUS plus surgical staging. And et al. 2015 studied EBUS versus mediastinoscopy under conscious sedation. And Bozema et al. In 2023 evaluated EBUS or EUS with combination with or without confirmatory mediastinoscopy. Now coming to the first study, the endobronchial ultrasound guided transbronchial lead aspiration of lymph nodes in the radiologically normal mediastinum. So it was primarily aimed to investigate the accuracy of the EBUS TBNA to stage the non-small cell lung cancer with normal mediastinal lymph nodes on CT image. Previously, in CT scans, the node which was suspected to be involved by the metastatic disease were evaluated with EBUS or EUS, but there was no significant role of doing EBUS or TBNA, EBUS or EUS in the normal mediastinal node. So this study investigated whether EBUS TBNA can be used in patients with normal mediastinal lymph. So patients with known or suspected non-small cell lung cancer underwent EBUS TBNA followed by surgical staging within 10 days. So all visualized lymph nodes between 5 mm and 10 mm were aspirated, while normal sized lymph nodes less than 5 mm were not. A primary endpoint was to see the diagnostic accuracy of the EBUS TBNA in sampling of lymph nodes less than 1 centimeter. So previously, more than 1 centimeter lymph nodes were considered as suspicious of the disease. So the chart here shows this initially CT scan was done. Then 100 patients were underwent 100 patients underwent the EBUS TBNA and then followed by surgical staging with either mediastinoscopy or thoracotomy with lymph node dissection. So in 85% of the cases, patient underwent thoracotomy and lymph node dissection. So despite negative CT scans, EBUS TBNA detected malignancy in 19 patients, and surgical staging identified 2 additional patients. EBUS accurately classified all 79 patients without N1 N2 disease, and overall it demonstrated a sensitivity of 92%, specificity of 100%, and negative predictive value of 96%. So it was concluded that EBUS TBNA can identify nodal metastasis in patients with radiologically normal mediastinal lymph nodes. So what the reviewer have a commentary on this is EBUS TBNA study by the Hirth et al. Is one of the early studies to put light on identifying nodal metastasis in patients without CT enlarged lymph nodes. So it has later influenced many subsequent studies comparing endoscopic staging technique to more invasive approach like mediastinoscopy. So this figure shows to give us a general idea of how and what are the lymph node maps reason that EBUS can be used for identifying or doing FNAC. So the levels are 2R, 2L. Along the airway, we are able to evaluate these nodes in EBUS. The 4R, 4L, 10R, 10L, 11, level 11, and level 7, and level 12L can also be used. Now coming to next study that was evaluated in this review was the minimally invasive endoscopic staging of suspected lung cancer by Wallace MB et al. So it was primarily aimed to compare the diagnostic accuracy of traditional TBNA versus EBUS FNA and combination of EBUS and EUS FNA. So patients underwent these procedures sequentially as a single combined procedure, and primarily it was evaluated. It was used to evaluate the sensitivity of these procedures in detecting lymph node metastasis in the mediastinum. So pathology confirmation and a 6 to 12 month clinical follow-up were the criteria standard. So 138 patients underwent these procedures in between 2004 and 2006, and 30% of whom were found to have nodal metastasis. EUS with EBUS FNA had the highest sensitivity and negative predictive value, while individually EBUS and EUS were higher in sensitivity and negative predictive value as compared to traditional TBNA. So it was concluded that combination of the EBUS and EUS was more diagnostically accurate and complete as compared with TBNA, EUS, or EBUS alone, and was performed without procedural complications. So this study provided us the unique opportunity to compare the paired comparison between these procedures. And Wallace also showed that showed that the combination of EBUS and EUS was superior to other procedures alone in patients who did not have a mediastinal adenopathy as such in CT scan. So likely because EBUS does not share the same blind spot at EUS because the presence of trachea and air inside the trachea creates a blind spot for EUS to evaluate the 2R, 4R, or 2R and 4R, station 2 and station 4 lymph nodes. So they give each other a complementary access to anterior and posterior mediastinum. So this figure shows the EUS landmark, as I showed the EBUS landmarks previously. Here we can evaluate the 2R. So in EUS, we can evaluate the 4R, and the level 7 lymph nodes. And sometimes if present liver lesion and para-aortic lymph nodes and even the left adrenal gland can be evaluated in EUS. Next study was the assessment of surgical staging versus endoscopic ultrasound, the ASTER trial. In 2010, it was published in JAMA by Anema, Zeti, and et al. So it was initially, the study was planned to compare the surgical staging mediastinoscopy with EBUS and EUS combined. But due to the guidelines requirement, it was later changed as surgical mediastinoscopy compared with EBUS, EUS in combination with the mediastinoscopy if the EUS, EBUS were negative. Primarily, it was analyzed to compare the surgical staging alone with endosonography followed by surgical staging. So here we can see the chart. Patients were initially selected and randomly assigned to either surgical staging alone, mediastinoscopy alone, or endosonography, which was later confirmed by mediastinoscopy. So if the nodal disease were found, no thoracotomy were done, a patient were diverted for alternative treatment like chemoradiation. If no mediastinal disease were found, then the patient were undergo thoracotomy and lung resection with biopsy, and the mediastinal lymph node dissection as per the final pathology was compared with the finding of the EUS and EBUS. So primarily endpoint was to see the sensitivity for detecting mediastinal nodes N2 and N3 disease. And secondary outcome include rates of unnecessary thoracotomy and procedural complications. So what they found was among the 241 patients randomized, 118 patients underwent mediastinoscopy, which has a sensitivity of 79%, as compared to the endosonography. 123 patients underwent the EBUS, and in which the overall sensitivity was 94% in EUS with EBUS. And unnecessary thoracotomy was done in 18%, and 7% were the cases in the endosonography group. Complication was similar in both the cases. So what they concluded was in patients with the suspected non-small cell lung cancer, staging with endosonography followed by mediastinoscopy, if negative, had a greater sensitivity than mediastinoscopy alone and was associated with the fewer unnecessary thoracotomies. So we could avoid unnecessary thoracotomies and added morbidity and mortality with use of the endosonography staging. So authors also found that the sensitivity improved from 85% to 94%, but about 11 patients needed to undergo mediastinoscopy after a negative endosonography to identify a single patient with nodal metastasis. Also, these findings challenge the utility of performing routine mediastinoscopy after a negative endosonography. So further, this trial, the data from this trial was used in other trials as well, and found that endosonography was associated with the lower cost due to reduced number of thoracotomy as well as better quality of life for patients undergoing staging. So this figure here shows what are the different nodal stations that we can actually get with EBUS, US, mediastinoscopy, mediastinotomy, and PATS. So as given in previous picture as well, these are the nodes that can be accessed by EBUS and US. And in mediastinoscopy, we achieve accuracy from 2R, 4R, 2L, 4L, 10, 7, and in EUS we achieve two different stations like 8 and 9, and in anterior mediastinotomy we access the level 6 and level 7, and in that we can access almost most of the nodes. Another study was endobronchial ultrasound versus mediastinoscopy for mediastinal nodal staging of non-small cell lung cancer. So it was the purpose was to study EBUS performed under general anesthesia. Initially, EBUS used to be performed under general anesthesia, but to have a more practical clinical use of EBUS, this was studied. This study evaluated the EBUS and its efficacy under conscious sedation. So, patient with suspicious N1 to N3 nodes with more than 1 centimeter lymph node in the CT or FDG positive avid nodes in the PET scan. So these patients underwent the EBUS TBNA followed by traditional cervical mediastinoscopy or PATS mediastinoscopy. The primary endpoint was to compare sensitivity of EBUS with mediastinoscopy. Secondary endpoint to compare the specificity as accuracy, positive predictive value and negative predictive value. And these were compared with the cytologic confirmation. So between 2010 and 2012, 127 patients were evaluated with both EBUS and mediastinoscopy. And in 59% of the patients, there was N2, N3 disease. On a per person analysis, EBUS demonstrated significantly greater diagnostic sensitivity, that is 88% as compared with 81. Accuracy also higher, 93 as compared to 89. Positive predictive value 100% versus 89%, and 85% versus 79% of negative predictive value as compared with mediastinoscopy, all with significant differences. And specificity was 100% for both the first. In subgroup analysis, EBUS was found to have a significantly more sensitivity at 4L paratracheal station. And authors concluded that EBUS performed under conscious sedation had better diagnostic sensitivity, accuracy, and negative predictive value for mediastinal staging as compared with mediastinoscopy. So, as after this trial, it provided significant information regarding effectiveness of the EBUS, and also emphasized its advantage in sampling lymph nodes located near delicate structures like 4L. But it did not evaluate the patient with enlarged pretracheal nodes, that is, in which mediastinoscopy is typically preferred. But all these evidences do support the EBUS as first-line procedure for mediastinal staging. Next study was the Medias trial, endosonography with or without confirmatory mediastinoscopy for resectable lung cancer, randomized clinical trial. Initially, guidelines recommended confirmatory mediastinoscopy even after negative endosonographic staging, but Bosima et al. Conducted this randomized control trial, non-inferiority study to evaluate the confirmatory mediastinoscopy is whether it is necessary following the negative endoscopic staging or not. So patients with proven or suspected non-small cell lung cancer underwent after negative systemic EVAs with or without EVAs were involved. And following a negative endosonography, patients were assigned to 1:1 immediate lung tumor resection, lymph node resection, that is immediate resection group, or a confirmatory critical cervical video-assisted mediastinoscopy group. The primary endpoint was to see the presence of unforeseen N2 disease after tumor resection with lymph node resection, and non-inferiority margin was 8%. Secondary endpoint included time to treatment and adverse events. So between 2017 and 2020, 360 patients were assigned after the negative endosonography as a group of confirmatory mediastinoscopy, 182 patients, or immediate resection, 178 patients. Interval to resection was 38 days in mediastinoscopy group as compared with the immediate resection group, which was 28 days. So in the immediate resection group, the unforeseen N2 disease was 8.8%. And in mediastinoscopy group, after the mediastinoscopy was detected, which was at 8%, patient underwent non-surgical treatment, while if no metastasis was noted, patient underwent thoracotomy and resection, in which the unforeseen N2 disease was 7.7%. And these two rates, as compared, were in the immediate resection group, it was non-inferior as compared with the mediastinoscopy group. So major morbidity and 30-day mortality was higher in the mediastinoscopy group, but this difference was not significant statistically. So authors concluded that EVAS alone is non-inferior to EVAS with confirmatory mediastinoscopy in patients with resectable non-small cell lung cancer. So this article, this study had also used the survival data from the ASTER trial as explained previously. And the authors demonstrated confirmatory mediastinoscopy after a negative systematic endosonography may be safely omitted in selected patients. While on the editorial, Farza et al. Showed a few limitations of these studies, as the studies has a much lower overall prevalence of the nodal disease as compared with the ASTER trial itself. But it did offer us a valuable insight regarding the differences between the invasive staging studies, including the staging accuracy, treatment selection, procedural risk, and time to treatment initiation. So future research should aim to identify the specific patients in whom mediastinoscopy is necessary following negative endosonography. So what current society guidelines are there? So there are different society around the world, like in the European society, there is different. In NCCN, there is different guideline. In American College of Chest Physician provide a different guideline. So ESTS has its guideline revised in 2014 recommends EVAS with EUS with FNA as the first choice in cases of enlarged mediastinal lymph nodes on CT or PET positive lymph nodes. 2024 NCCN guideline, although these are revised quite frequently, suggest patients to undergo the least invasive biopsy with the highest yield as the first diagnostic study. And American College of Chest Physicians recommend performing a needle-based biopsy, EBUS, EUS, or EBUS with EUS as the best first step overall over surgical staging in patients with or without a discrete nodal finding on the CT PET. So, what are the future directions of this field? There are studies which are actively recruiting participants. So this include the sequence trial, in which they are evaluating the diagnostic yield of robotic assisted bronchoscopy when staging EBUS is performed first or second in the same process. So it is a multi-center randomized clinical trial aiming to determine whether sequence of staging EBUS plays a role in diagnostic yield, incidence of atelectasis, and safety outcome in patients undergoing robotic-assisted bronchoscopy. Another study is the augmented endobronchial ultrasound (TBNA) with artificial intelligence to use the AI algorithm to identify lymph nodes and blood vessels examining the EBUS. And negative endobronchial ultrasound (nebula) is a non-blinded randomized control trial aiming to determine whether a combination of robotic EBUS or electromagnetic navigation bronchoscopy is superior to ENB alone in sampling of lung nodules. So take-home message is studies have supported a shift toward less invasive mediastinal node staging. So a combination of EBUS with EUS or EBUS alone is shown to have a superior alternative to cervical mediastinoscopy. But realistically, this may not be feasible at many institutions because of the availability of the resources and technical expertise. While confirmatory mediastinoscopy can be omitted in selected patients with the use of EBUS and EUS. Thank you.
Thank you, Dr. Moyes. So few things. It's so like the important, right? In the copy budget, so first we have to go and read the Mediastinal because there have been several lectures about the CT scan, bronchoscopy, etc. And we concluded. So as of now, हामीले के भन्नुपर्छ what has been suggested, guidelines. कुनै patient non-small cell, whatever lung cancer, mediastinal staging is must if it is not stage 4. If it is stage 4, then the highest thing we have to diagnose that is really stage 4. Lung lesions or node lesions or brain metastasis or skin metastasis. Sabanda less, sabanda highly appreciable, just invasive way as I approach the biopsy. Not the lung lesion, not the node, but the skin mess. This is the highest point. If it is stage 4, then potential resectable patient on success. That can be taken for the surgery. And so for that point of view, he said that the nodal mediastinal staging is very important. Yadi kasayko N0, N1 potential curable, you can send the patient for surgery. If N2 surgery, still it is questionable, you can, after some sort of treatment, you can convert into the surgery, still curable. But beyond that N3 surgery, you don't take for the surgery, etc. So therefore, mediastinal staging is very important in that is potential resectable category. अब यो स्टेजिङ कसरी गर्ने त गाइडलाइनले के भन्छ भने एनसिसिएनले मैले त भन्यो अलिकति त्यही पनि म स्ट्यान्डर्ड वेमा के भन्न चाहन्छु इन द वेस्टर्न सोसाइटी एनसिसिएन गाइडलाइन्स एस्मो गाइडलाइन्स एभ्रीबडी अब अमेरिकन सोसाइटी थोरासिक सर्जन गाइडलाइनले के भन्छ भने कि इफ इट इज पेरिफेरल लिजन पेरिफेरल T1 भन्नाले इफ द साइज इज लेस देन 3 सेन्टिमिटर located in the outer 1/3 of the lung, that is the peripheral lesion, right? In peripheral, there is no nodes on the CT scan. If it is negative, then you can take the patient up front for the surgery. Even in such cases, you can avoid PET scan. The CT scan is must, because you must know about the size criteria, etc. So if it is peripheral, less than 3 centimeter T1 lesion, periphery located, CT-wise N0, then you avoid the PET scan. If the similar lesion is located centrally, then you have to consider PET scan. First stage you do is the PET scan. PET scan, if it comes negative, if it is not peripheral, then you have to prove it. So really it is negative. And you have to prove by various ways that he has mentioned, EBUS, EUS, mediastinoscopy, VATS, etc. That's truly negative is by invasive way, like the methods like EBUS, EUS, it's negative, then you can take the patient for surgery. Actual pathway, or if it's not fit for the surgery, then alternative. If it comes to be positive, then again you have to prove it is truly positive. When you use selection of very positive, if you positive you take for the neoadjuvant treatment, then surgery is feasible or not feasible, you have to decide. यो त बुझ्यो न अब चाहिँ के गरौँ भने अब out of the various places that the trials that you have mentioned, various trials, पहिला क्लासिकली हामीसँग डक्टर विश्व श्रेष्ठ हुनुहुन्थ्यो सिएमसीको. He was the first fellow from CMC and he has been posted for 3 months. His thesis was I think thesis was under के भने TB transbronchial FNA. भन्नाले blindly that he mentioned in the first trial के गरिन्छ भने जस्तो CT scan मा you see visualize if there is the subcarinal lymph node. Then you do the bronchoscopy, you do not visualize the node like in the E-bus because you don't have the ultrasound. Conventional, you see the CT scan, there is a node, then blindly through it you puncture the needle, pass it here, and take the FNA. The classical way of taking the पहिला historical way of taking the FNA, the chances of error are there. The positive predictive and negative predictive are very less, and also the complication might happen because it's blinded and you can puncture the vessel. So this is the way पहिला यसरी गरिन्छ. So now the first trial showed that TBNA, transbronchial needle aspiration, should be avoided. First trial को mention this question एकदम poor result गर्न हुँदैन भने first trial को भयो. Second, what we do is the classical way next step was the mediastinal scope. तिमीले देख्यौ mediastinal हामीले गर्यौं हैन सजिलै. देखाएको छैन रहेछ. त्यो यो देख्नुबाट कुनै केसमा भन्छ. Mediastinal scope are of two types. One is the standard cervical mediastinal scope. So this is the neck, this is the sternum. We make like thyroid incision or 2 inch in length, then pass this into the trachea wall, and then with the lymph nodes 2R2L, 4R4L. Then you go 10R can be sampled and 7. This much of the lymph nodes can be sampled by the mediastinal scope. That's it. But if somebody has level 7, मतलब जस्तो कि यो 7 भन्नाले 8 हो esophagus or AP windows 5, 6 lymph nodes, they cannot be sampled. Right? The classical mediastinal scope does sample to किनभने हामी यसरी pass गर्छौं along the trachea. So definitely upper paratracheal, lower paratracheal, right bronchial, the subcarinal lymph nodes can be sampled. This is the standard cervical mediastinal scope. The one of the French North Canadian author said कि यसको main चीज के छ भने left side मा you must give the metastasis level 5 and 6. भन्नाले यो टिकार सबसे AP window generally left side को tumor कहाँ दिन्छ? AP window मा दिन्छ, यहाँनिर दिन्छ 5 and 6. So for the left sided mediastinal scope cannot be done. Well, it's not very appropriate. Most of the lymph nodes that are metastatic cannot be taken up by the cervical mediastinal. उनीहरूले के एउटा plane deviate गर्यो into the in between innominate vessels and trachea go. That is called extended mediastinal scope. Just one level 5 and 6. Now you're quite complicated. I have never done. I have seen it. A lot of error might happen. You can rupture the vessels. They were I don't prefer the intent because I have never done myself. I have seen them only doing it, and most of the surgeons worldwide also don't prefer it. They were next step avoid communication. That's called extended mediastinal scope. Avoid like अर्को procedure invent गर्नु left side को लागि त्यसको mediastinotomy. Left side को यहाँनिर incision दिने chamberlain incision गर्छ हैन. Second intercostal scope space मा त्यहाँनिर scope हाल्ने mediastinal scope. Under vision, you take out those lymph nodes. Left side, the lymph nodes you can visualize, but it's more invasive. You put it appropriate, but the standard way after mediastinal scope, left side mediastinal is one of the options. Next came the Polish and Swedish. Only invented the very extensive lymph node that is called Gamla and Temla. Gamla, video assisted mediastinal lymphadenectomy. Unic's purpose case of any. Why do we do surgery twice? You make a bigger incision, you retract to lift the sternum line, you go with the mediastinal scope, a longer scope, you can take out the lymph nodes in the both sides of the chest cavity. That will exclude even N3 disease. Send for the frozen. If the N3 is negative, you complete the mediastinal lymphadenectomy by this method. Scope यहाँबाट छिराउने, not only dialysis, even therapeutic. That's quite time consuming. Expertise is required. Again, I have never done myself. I have only seen. When a Temla and Vimla, two of the options, that's my totally complete mediastinal lymphadenectomy, all around say even left and right sakinsa. So this is one of the options. Now next, these are the more invasive ways. The next less invasive that he said is the EBUS and EUS. And EBUS and EUS will be after plus and minus points. So EBUS will clearly answer one because we are traversing the EBUS endobronchial ultrasound. We are going through the airway. So definitely this lymph nodes 2R2L can be sampled. Lower paratrancheal 4 and 4 can be sampled.
3 also can.
Carina, we go 3 cannot be sampled because the
3
prevascular.
anterior can be sampled, posterior can be sampled.
3A भन्नाले prevascular so we don't miss it. यसबाट मिल्छ EUS बाट मिल्छ सरी EUS बाट मिल्छ EUS बाट मिल्छ भने चाहिँ यो लेभल 7 lymph nodes किन एयर मेजरमेन्टमा यसमा sample level 3 as mentioned by Dr. Sara
7 पछि इम्प्रुभ छ सर
गराउने छ then we can sample 10 hour यो sample गर्ने छ 11 किन एयर वेमा यहाँसम्म रोकस त जान्छ नि will perhaps the interval over 11 so when 11 both sides can be sampled so these lymph nodes can be sampled by EBUS but those lymph nodes located at the 5 and 7 and 5 and 6 sorry and 8 9 cannot be sampled right this को लागि the best one is the EUS and this will be ultrasound बाट त्यो गर्न सकिन्छ भने so the next answer is EUS the second trial said that mediastinal has the better result but if you compare the EBUS and EUS versus mediastinal, it's supposed to be superior. No need. Even combined was better result. But whatever, I think the less invasive way is the EBUS, EUS type, some of the appropriate next steps could be the VATS, if that were possible. The VATS, but all the lymph nodes can be sampled from one side only. The right side go VATS, or right side go nodal staging. The left side go on side. EBUS, EUS has the advantage of sampling both sides. And to a difference, N3 disease can be excluded very well by EBUS, EUS or TEMLA, but not by the VATS. VATS बाट single site को thorax बाट VATS गर्ने हो त्यसबाट गर्छ. Now coming to यो त clear भयो हैन. Now coming to your part, उहाँले मैले नोट्स देखाउ त फ्लो चार्ट हेर्नु एउटा सुरुको ट्रायलको फ्लो डायग्राम दियो तिम्रो
पज गर्नु
ठिकै छ केही भएन मलाई के लाग्छ भने सौजनको लागि देयर वाज अ भेरी गुड डायग्राम यु क्यान गो इन्टु द्याट एन्ड लुक मलाई के लाग्छ सौजनको लागि आउट अफ दिस होल फर्स्ट यु सुड लर्न टु स्टेज इट बाई द सिटी स्क्यान कसरी थाहा पाउने मलाई के लाग्छ हामीले के गरौँ भने फ्लो चार्ट जसरी म यसले त्यहाँ पुट गरेको छु इन द रिभ्यू आर्टिकल एउटा सिटी नोड ऱ्याट ठिक छ बाई सिटी नोड ऱ्याट यु डिटेक्ट हामीले इन्क्लुजन क्राइटेरियामा राख्यो T1 to T3 because they are potentially receptive. We take only non-small cell carcinoma. We take only T1 and T3. T4 is the exclusion criteria. The stage 4 is the exclusion criteria. N3 is also exclusion criteria. When I mean inclusion T1, T3 हुनु पर्यो. N0, N1, N2 हुनु पर्यो. N2 सम्म हुनु पर्यो. And 937 हामी युज गर्छौं. 937 and 837 नलियो. त्यसपछि फिट पोटेन्शियली क्युर सर्जिकली डिसेक्टेबल हुनु पर्यो र फिट फर सर्जरी हुनु पर्यो यति इन्क्लुजन क्राइटेरियामा राखेको सर्जिकल कन्सेप्टले चाहिँ गर्ने भने चाहिँ T1 T3 छ र सिटी नोड राइडर्सबाट N0 आयो सिटी नोडले N0 देखाए वा N1 देखायो भने हामी अपफ्रन्ट सर्जरी गर्छौं फाइनल जुन बायोप्सी आउँछ त्यसले कम्पेयर गर्छौं सिटी नोड वाज ट्रुली पोजिटिभ र ट्रु अर यसमा त ट्रु नेगेटिभ हो नि यसले त N2 नेगेटिभ देखायो नि when was really negative by CT node rat is truly negative by the final pathology. बुझ्यौ किन हामी सर्जरी गर्न गइरहेछ ठीक छ यदि सी नोड ऱ्याट्सले चाहिँ N2 डिजिज देखायो भने चाहिँ यसमा we go for CT node rat भने we go for EBUS EUS whatever हैन अनि what mediastinal whatever यो गरेपछि then if it comes negative then we go for surgery. ठीक छ now this will be confirmatory यसलाई कम्पेयर गर्ने नोड ऱ्याट्सको स्कोरिङ छ if truly यो नेगेटिभ छ भने really it was negative भने 2 पोइन्ट्स चेक पोइन्ट भयो एउटा EUS EBUS को पनि सेन्सिटिभिटी र स्पेसिफिसिटी हामी हेर्न सक्यो र सेकेन्ड चाहिँ फाइनल र हामी कम्पेयर गर्ने नोड ऱ्याट्समा पनि ठीक छ if it comes to be positive N2 भने पोजिटिभ देखायो भने we then go for the neurosurgery chemotherapy and then we do again node rat again do node rat after chemotherapy then do the surgery अब यहाँको node rat ले यो सर्जिकल फाइनल बायोप्सीसँग कम्पेयर गर्ने फाइनल बायोप्सी त्यसैले कम्पेयर गर्ने भने यसलाई यससँग त कम्पेयर गर्न मिलेन कि न्युरोजमेन्ट केमोपछि रेस्पोन्स गरेको हुन सक्छ यो तिमीलाई कस्तो लाग्छ सबैजना ओपिनियन भन्नु के फ्लो चार्ट उसको लागि के
युएस मात्रै छ के
सबै भएन युएस न गर्ने युएस गर्छ
T3 को पनि तीनटा भेरिएन्ट हुन्छ नि सर T3 साइज भेरिएन्ट हुन्छ एउटा इन्डिजिभ र स्याटेलाइट भेरिएन्ट हुन्छ हैन
त सबै सर्जिकली ट्युनेबल भयो सर्जरी गर्न मिल्यो मिल्यो टेस्टिङ सेम लो भयो लोबेक्टोमी गर्न मिल्यो T3 भनेको सेम लो
होइन
T4 भनेको डिफरेन्ट लोबमा, T3 भनेको सेम लोब,
T3 सेटेलाइट भयो भने पनि मिल्यो
सेम लोबमा के मिल्यो नि, सेम लोबमा अप्पर लोबमा T1 छ, सेम लोबमा दुईटा डिभिजन भयो के, त्यो मिल्यो T3
लोबेक्टोमी गर्न मिल्यो।
दुईटाको जोडिन्छ कि के हुन्छ त्यसमा सेटेलाइट
जोडिँदैन, स्याटेलाइट मेन रिजनको क्लासिफाई गर्छ, गर्छ भन्ने T3 हाइएस्टले क्लासिफाई गर्ने,
सर अनि एउटा स्टेसनबाट मात्रै लिने युएसबाट
नलिने एउटा स्टेसनबाट पोटेन्सियल जो एक्सेसिबल छ त्यहाँबाट लिने, त्यो
भने सर
चाहिँ
हाम्रो सर्जिकल मैले के सोध्नु के भन्दा सेटेलाइट त मिल्यो जस्तो सुनिरहेको थियो मैले पहिला
के गर्नु
लोबिटोमी गर्नलाई कि
किन मिलेन मिल्छ
मिल्दैछ है
मिनिमम लिम्फ नोड स्याम्पलिङ र मिनिमम लिटल पासेस कति हुन्छ सर त्यो अन्डरस्ट्यान्डिङ
12 to 15 हो, 3 स्याम्पल्स लिनु पऱ्यो, 12 to 15 को। अब र कुरा के भने अब सबै स्टेसन हामी स्याम्पल गर्न सक्छौँ, लेट्स से सिनारियो हो कि अब हामीले डिस्कसन गर्नु के कुनै पेसेन्टको यहाँनिर डिभिजन छ राइट लोअर लोबमा, प्रोबाबिलिटी सुपेरियर मेडियास्टेनमको लेस हुन्छ होइन, तर त्यसलाई सर्जरी गर्न सकिहाल्यो नि, T1 T3 सर्जरी गर्न मिलिहाल्यो नि, पुरै सिकिहाल्यो क्या, झन् बढी मान्छे सर्जरी भयो। र खालि एउटा कुरा के छ भने इभेन जो बल्की छ त्यसलाई पनि लिउँ के सर्जरी नगर्न मिल्यो पनि होइन, सर्जरी नगर्न त्यसलाई यहाँसम्म त कम्पेयर गर्न मिल्यो नि, बुझ्यो न, स्टेजिङ छ हामी सर्जरी गर्नै पर्छ भने मस्ट नराख्नु के, पोटेन्सियली सर्जरी बट त्यहाँसम्म एन्ड नगरौँ क्या, त्यसो भए स्याम्पल कलेक्सन इजी हुन्छ, हामीसँग
N2A फेरि N2B पनि छ त्यो
छुट्टै दिने 9th एडिसनमा बल्की आयो होइन, हामीले कहीँबाट प्रुभ नगर्नु छ, प्रुभ त गर्नु छ, यदि मानव यो पोजिटिभ आयो भने सक्यो उसको यहाँनिर गरिदिने कि यहाँसम्म नलाने छोडिदिने झन्झट, यहाँसम्म एन्ड गरिदिने भने यो ट्रु पोजिटिभ भने यो पनि ट्रु पोजिटिभ आइसक्यो सक्यो, यो ट्रु पोजिटिभ देखियो तर यहाँ नेगेटिभ आयो भने सर्जरी गर्ने, कुनै अर्कोबाट प्रुभ गर्ने,
सर्जरीबाट सबै फेरि फाइनलिस्ट प्याथोलोजी
आइहाल्छ भने त्यो चाहिँ मानव कि बल्की छ हामीले यसमा नेगेटिभ देखाइदियो भने त्यो एउटा मेथोडोलोजी सेक्सनमा राख्नुपर्छ कि बल्की बट बस युएस नेगेटिभ, त्यसको पनि सेन्सिटिभिटी त 100% हुन्न नि, यदि नेगेटिभ छ भने स्टिल अनएक्सेप्टेबल छ भने द वी डु बाई मेडिया अर भ्यास यसको प्रुभ गर्ने, त्यो झन् राम्रो भयो, यतिसम्म एन्ड गर्ने, ठिक छ कस्तो लाग्छ तिमीलाई पोटेन्सियल रिसेप्टेबल N2 जस्तै अनरिसेप्टेबल भयो एज सच होइन, पोटेन्सियल रिसेप्टेबल
अनरिसेप्टेबल भन्नु पर्यो क्या
N2A त फ्युमा रिसेप्टेबल मिल्यो, N2B चाहिँ अनरिसेप्टेबल भयो, त्यसलाई पछि रिसेप्टेबल बनाउनु मिल्छ नि होइन, तर मानव उसलाई N2B हामीले देखिरहेको छ सिटी वाइज तर ई बस युएसमा आएन, त्यहाँ सर्जरी गर्न मिल्दैन, हामीलाई थाहा छ कि गर्ने कि नगर्ने कि त्यसलाई चाहिँ बरु अरू वेबाट प्रुफ पो गर्ने हो कि भने चाहिँ त्यो एउटा चाहिँ त्यही भएर चाहिँ मलाई के लाग्छ भने मेथोडोलोजीमा 9th एडिसन एउटा इन्क्लुड गर्ने होइन, ओन्ली N2 डिजिजसँग दिने, N2 बाहेकको लिने, ई बस युएस मेडियास्टिनल सबैको तिमीले डिस्क्राइब गर्नुपर्छ मेथोडोलोजीमा, झन् पेपरबाट झन् राम्रो नि, थेसिसको पेपरहरू पढेको राम्रो नि होइन भने वाट इज ई बस, वाट इज युएस, वाट इज मिडिया, हाउ यु डु इट, विच लेभल स्टेसनको चार्टिङ देखाएको छ, अब मेरो लेक्चर त बुकमा पनि छ, विच स्टेसन्स विल बी, लास्ट टाइमको पनि मैले एउटा चार्ट दिएको छ, विच स्टेसन्स विल बी डेल्ट बाई द ई बस, विच स्टेसन विल बी डेल्ट बाई युएस, द वे डुइङ नाउ युएस भन्ने डोन्ट मेन्सन, पब्लिक राख्ने ई बस युएस के भयो त्यो होइन, एनिवे मेडियास्टिनल कुन मेडियास्टिनल म्यापिङ गर्ने भनेपछि चाहिँ इन्क्लुजन क्राइटेरियामा सुड बी रिसेप्टेबल T1 T3 N0 N2 N2 will be divided N2A N2B, then should be fit for surgery at the time of diagnosis patient should be fit for surgery, echo status 0 to 1 ठीक छ, अनि PFT राख्ने कि नराख्ने फेरि तिमीहरूले अब विचार गर, PFT सायद नराख्नु किन क्वेसनेबल हुन्छ है, PFT मात्रै गर्यो DLCO गरेर क्यान क्वेसनहरू किन ल्याउने होइन, त्यो सिम्पल चार्ट मैले यस्तो बनाएको थिएँ र यो मैले लेखेको यहाँनिर कस्तो राखेको तिम्रो होइन त्यो उसको थेसिसमा नराख्ने, थेसिसमा धेरै क्वेसनहरू आउन सक्छ क्या
डाक्टर अहिले प्रेजेन्टेसन राम्रो दिनुभयो